Hello, my name is John Mancini. I'd like to present on behalf of Diabetes Canada the clinical practice guidelines for dyslipidemia. I would like to do this on behalf of myself and my co-authors, Robert Hegley and Lawrence Leader. Key changes in the guidelines are listed here. We promote use of either fasting or non-fasting lipid profiles, and the non-fasting particularly in those without hypertriglyceridemia. We clarify new lipid targets, indicating that LDL should be consistently below 2 millimolars per liter, or greater than a 50% reduction from baseline. We also underscore the potential use of alternate targets, such as ApoB, with a goal of less than 0.8 grams per liter, or non-HDL cholesterol, with a goal of less than 2.6 millimolar per liter. We also highlight the emerging role of PCSK9 inhibitors. The dyslipidemia checklist consists of checking the lipid profile at the time of diagnosis and then yearly or every 3 to 6 months when on treatment, use of statins as the first line of therapy, use of add-on second-line agents only when LDL goals are not being met with statin therapy, and limited use of fibrates when triglycerides are above 10 millimolar per liter. Measurement of lipids at diagnosis should be repeated yearly if treatment is not started. It should be repeated more frequently, such as every 3 to 6 months, if treatment is started or if the patient is already on treatment. A fasting profile should be after at least an 8-hour fast and will consist of the full lipid profile. The non-fasting profile might consist of the same full lipid profile or ApoB, or particularly a focus on non-HDL cholesterol, which is the total cholesterol minus non-HDL cholesterol. These options should be most convenient for patients, therefore allowing non-fasting profiles as well. Dyslipidemia in diabetes is quite complicated and consists of a diversity of abnormalities as listed here. From a practical perspective, the main therapeutic issues revolve around the LDL cholesterol and the ApoB, or the non-HDL cholesterol. Who should receive statin therapy? This has been demonstrated in randomized clinical trials, including the heart protection study. And in the subgroup with diabetes, one can see that there is definite risk reduction in all categories with prior MI or other CHD, with no prior CHD, and with CHD or no prior CHD. Similarly, in the CARDS trial, the effect of statin for primary prevention in type 2 diabetes was assessed in almost 3,000 patients. These were adults 40 to 75 years of age with no prior history of CVD, and they had type 2 diabetes with the comorbidities of either retinopathy, albuminuria, hypertension, or smoking. The intervention was low-dose atorvastatin versus placebo, and the outcome was acute coronary syndromes, revascularization, and stroke. As we see here, the primary endpoint was significantly positive, including significant reductions in acute coronary syndrome and stroke, and trends that were concordant in the endpoint of coronary revascularization. The secondary endpoint of death from any cause was concordant with overall risk reduction and highly significant in the setting of any acute cardiovascular disease event. Accordingly, statins should be provided for those with clinical cardiovascular disease or adults 40 years or older with microvascular complications or with long-standing 15-year duration and age above 30. Also, these guidelines are concordant with the CCS guidelines, and therefore these recommendations are quite consistent. It should be noted that among women with childbearing potential, statins should only be used in the presence of proper preconception counseling and reliable contraception. Statins should be stopped whenever possible prior to conception. If the baseline LDL is less than 2, there is often clinical concern as to whether these patients warrant therapy. The CARDS and HPS trials outlined previously indicated that the subgroups that started even with lower baseline LDL cholesterols still benefited to the same degree as the whole population. So in a person with diabetes who qualifies for statin therapy, the statin should be used regardless of the LDL cholesterol, and in this case, trying to achieve a greater than 50% reduction should be the focus of treatment. The statin options are listed here alphabetically with the generic names in the left-hand column, the trade names in the middle column, and the considerations in the right-hand column. These are indicated primarily for lowering LDL cholesterol because they have only a modest triglyceride lowering and HDL cholesterol raising effect, and even then only at higher doses. If on therapy, the target should be an LDL cholesterol consistently less than 2 millimolar per liter. Statin therapy should be used in the context of broad global cardiovascular risk reduction, which will include smoking cessation, careful attention to calorie restriction and dietary patterns, including low saturated and trans fatty acids, low refined carbohydrates, inclusion of viscous fibers, plant sterols, nuts, soy proteins, and moderation in alcohol use. And of course, physical activity should be included in this as well. Second-line agents are shown alphabetically here and should be used if the LDL target is not reached with maximally tolerated statins. Of these agents, there are multiple, but the cholesterol absorption inhibitors and the PCSK9 inhibitors are the predominant ones being used. The drug classes are listed here in the left-hand column. The principal effects are shown in the middle, and other considerations, particularly any characteristic side effects, are summarized in the right-hand column. With regards to add-on to statins, there are several important trials to highlight. The first is the Improve It trial, which showed the effect of ezetimibe add-on to statin and the fact that it reduced cardiovascular events in people with acute coronary syndromes, and particularly in those with diabetes. Those with diabetes had a higher overall risk, and this was lowered significantly, whereas the patients without diabetes were at an overall lower risk, and in this study, using a fairly weak intervention, there was no real difference in the risk reduction in patients without diabetes. The Fourier trial is the first PCSK9 outcome trial showing its effectiveness as an add-on to statin therapy. This agent reduced cardiovascular events, and this analysis is stratified between those with diabetes, shown on the left, and those without diabetes, shown in the right-hand panel. Again, one can see that patients with diabetes and concomitant coronary disease have a higher overall risk, and in this case, a very significant lowering when randomized to evolocumab. The risk reduction was 17%, with an absolute risk reduction of 2.7%, leading to an NNT of only 37. In the right-hand panel, the overall risks are lower. The relative risk reduction is significant and is 13%, but the absolute risk is somewhat lower at 1.6%, and therefore the NNT is somewhat higher at 62. If triglycerides are markedly elevated above 10, then selective use of fibrate is recommended in order to reduce the risk of pancreatitis. Of course, glycemic control must be optimized, as well as healthy behaviors that will affect the triglyceride, including weight loss, other dietary strategies, particularly avoidance of alcohol. Recommendation 1 is shown here and suggests that a lipid profile should be fasting or non-fasting and should be measured routinely. In those with known hypertriglyceridemia, a fasting profile should be performed. If lipid-lowering treatment is not initiated, the profile should be reconsidered every 1 to 3 years based on the background cardiovascular risk of the patient. If patients are treated, then more frequent monitoring at 3 to 6 months to ensure achievement of goals is warranted. People with diabetes and indications for lipid lowering should be initiated with a statin, and the goal is to achieve LDL consistently below 2 or consistently greater than a 50% reduction in the LDL cholesterol. When following ApoB, the respective goal is less than 0.8 grams per liter, and non-HDL goal is less than 2.6 millimolar per liter. In people with diabetes achieving these goals with statin therapy, the routine addition of fibrates or niacin for the sole purpose of further reducing cardiovascular events should not be used. For individuals not at LDL goal despite statin therapy at maximally tolerated doses, a combination with a second-line agent can be considered. Generally, ezetimibe should be considered, and in people with diabetes who also have concomitant clinical cardiovascular disease, ezetimibe or evolocumab may be considered, and the choice can be based on the size of the existing gap to LDL goal. In patients who have familial hypercholesterolemia, evolocumab can be considered as well. For individuals with diabetes with fasting serum triglyceride above 10, a fibrate should be used to reduce the risk of pancreatitis while also optimizing glycemic control, healthy behaviors, and avoidance of excess alcohol. The key messages are summarized here. Beneficial effects of lowering LDL cholesterol with statin therapy are equally applicable to people with diabetes as to those without the disease. Primary treatment goals for people with diabetes is an LDL cholesterol consistently less than 2 millimolar per liter or consistently greater than a 50% reduction from baseline, including those patients with low LDL to begin with. Alternative targets and goals are for non-HDL cholesterol less than 2.6 millimolar per liter, or for ApoB less than 0.8 grams per liter. Achievement of the primary goal may require intensification of healthy behavior interventions in conjunction with statin monotherapy, and on occasion the addition of other lipid-lowering medications may be required. Key messages for people with diabetes are as follows. Most adults with diabetes are at greater risk for cardiovascular disease, such as heart attack and stroke. People with diabetes have an increased risk of cardiovascular diseases, even if their LDL cholesterol is so-called normal. They have an even higher risk if their LDL cholesterol is frankly elevated. Adults with diabetes should have their cholesterol tested yearly or as indicated by your healthcare provider. More frequent testing may be necessary for people taking cholesterol medications. Always discuss your cholesterol results with your physician or nurse practitioner and other members of your healthcare team. We encourage people to visit guidelines.diabetes.ca for teaching tools and other helpful educational material. Apps are available for both the Android from Google Play and the iPhone from the App Store, and these may be useful and convenient to use. Again, the main website is indicated here, and for people with diabetes, the www.diabetes.ca website is very useful. Thank you very much.